Welcome to Texas Heart Institute podcast series on the living legends and luminaries in endovascular medicine. Our guest today is Dr. Gary Rubin. Dr. Rubin is an internationally renowned interventional cardiologist celebrated for his groundbreaking work in the development of the first FDA-approved coronary stent, his pioneering work in carotid stenting, embolic protection devices, and large-bore vascular closure technologies. Dr. Rubin, thank you very much for accepting the invitation to participate at Texas Heart Institute podcast on living legends and luminaries in endovascular medicine. You're certainly one of them. We have lost many of those that are remarkable as far as their achievements are concerned, such as Charlie Daughter, Andreas Grunzing, Mason Soles, Cribier, just to name few of them. So it's a unique opportunity to hear from you the evolution and development in endovascular medicine. But let's start with your early beginnings and your native country of Australia. As you mentioned in your memoirs, you took a long track into medicine. In your teenage years, you state you only had a dream to become a horse whisperer. And then you got involved into veterinary medicine and practiced veterinary medicine. So maybe you can tell us what was the circumstance that helped you fulfill your long-term goals to go into medicine and eventually to become a cardiologist?
Bonko, great to be with you. And it is true that I started work on farms and ranches in outback Queensland, and then went into veterinary medicine. So importantly, I had a life, an experience in the world prior to entering medicine, which I think really provided an advantage for me as I then pursued my career. I must say that it was a wonderful life, but let me say at some point I felt that spaying cats and castrating horses, I could make a much bigger contribution to the world by moving into human medicine. And that's really where I went, and pursuing cardiology later, and then a PhD, and then being extremely fortunate to have found Andreas Grunzing when he moved to the United States. Around 1980, I met him and finally got to Emory University a year or two later.
Gary, can you tell us what was the circumstance and when did you meet Andreas Grunzing?
Well, I was doing a lot of cardiac catheterization in the late 79, 78, and we were watching a video of his early work that one of our attending cardiologists brought back to Royal Prince Alfred Hospital. At that time, because you remember, everyone went to open chest, sternotomy, bypass surgery, and it was not a really good procedure back in those days. We were astounded watching this video of this blockage being removed by this guy in Switzerland using a balloon. So I had already applied to some fellowships in the US, but once I saw that, I wrote to Andreas Grunzing, who was then at Emory, and said, look, I hear you're coming to Australia to the Cardiac Society meeting. Can I meet with you to talk about getting a job with you? So that's how it happened. A very lucky interaction.
So I guess it happened in Melbourne, right?
It happened in Melbourne, 1980, yeah.
So, and then your life changed forever, which is absolutely amazing when we look at your achievements and history. Let's move fast forward just for a short segment. There was another well-known Australian, Bill Cook, that helped you, and in those early developments was instrumental for development of a balloon expandable stent. Can you mention a little bit about that communication and interaction?
Oh, of course, yes. Well, Bill Cook was non-Australian. He was a boy from Bloomington, Indiana, who had this very small medical device company was very interested in making catheters and all sorts of balloons and things particularly for radiologists. But Andreas Gunzig had met Bill Cook, and through Bill Cook, a radiologist called Cesar Gianturco, who was a retired interventional radiologist, had been fiddling with self-expanding stents and balloon expandable stents. And it was really Bill Cook's company, and particularly someone called Brian Bates, who was the product development manager, who brought Cesar Gianturco down. Andreas introduced him to me. It was only a month or two later that Andreas tragically died. And I took up this relationship with Cesar Gianturco and the Cook Incorporated to see if we could solve the problem of abrupt closure, which was really holding Andreas Gunzig's method of balloon angioplasty back at that time. So that's really the background of dealing with the stenting part of the coronary stenting part of my career. And Zonko, I will say that it is hard for investigators, innovators, cardiologists in this era to understand how difficult it was back in the 1980s to propose that we could put metal into a coronary artery to hold the artery open, this constantly beating artery. And interestingly, because of my veterinary background, we established a research lab at Emory University. We published a lot of work to prove to the skeptics that we could put a stent in a coronary artery and we could use a balloon, and that would solve this problem of the artery collapsing after Andreas Gunzig's balloon angioplasty. So as I look back, that was really the beginning of the innovation that carried me through for the next 40 years. It was the unmet need to solve the problem of abrupt closure after Andreas Gunzig's balloon angioplasty.
It's very interesting. There is almost like a common theme about related to early developments of endovascular medicine. A lot of those inventors and luminaries had also experience in surgery or dabbled into surgical approach for treatment of various vascular conditions. And like you mentioned, it certainly helped you to have had experience in veterinary medicine and surgery, because when you were doing the animal studies at Emory University, that was pretty natural to you to be able to do that research and carry on with the project to a fruition and the development of the final product.
That's absolutely correct. It's been said that good ideas survive in science and medicine despite really intense and repeated efforts to disprove them. And if you think about first balloon angioplasty and then coronary stenting, well, we think of how many studies we've done now to try, that others have tried to disprove its effectiveness and safety and efficacy. And yet we did it. And we did it based on a lot of very good basic research back in the 1980s, and it survived. And I would also add one other very important thing about my career with endovascular procedures, and that is the need to do randomized trials. And I have to say it takes great effort and courage and work when you're a proceduralist and patients said to you to ask the patient if they'll participate in the trial where they don't get the procedure. For me, it was stenting or angioplasty, but we had to randomize them to surgery, bypass surgery and a sternotomy. And I think it's undervalued. Those of our colleagues, including ourselves, who have spent the hours and hours doing this work with randomized trials to create good science, because that's how we found ourselves today, where we have validated the work that we do.
So let's move to another area of your great contributions and interest, and this is carotid artery stenting. How did you get involved in this area of endovascular intervention?
Well, that's very interesting because it was not many years after we began all the coronary stenting that I was approached actually by a board-certified neurologist, and he had noted that then we were actually using stents to take care of patients with acute myocardial infarction. In fact, I think our group published the first stent ever used in a STEMI patient, but successfully. This neurologist said, "Well, we're not doing anything for stroke. How can we use the techniques you are using for STEMIs for unstable angina patients in TIAs and strokes?" I said, "Well, let's look into this." And so we realized the carotid bifurcation, which was an important source of strokes, was something that we could reach with our balloons. And working and collaborating, I think this is another very important point. At that point, I met a neuroradiologist at the University of Alabama, Yuri Vitek, and together, working with some neurosurgeons at University of Alabama, I must say, not the vascular surgeons, but the neurosurgeons, we were able to begin the process, now a close to 30-year process of developing carotid stenting, and then carotid stenting with embolic protection, and then again, randomized trials, because we always require science. Well, we had to deal with the skepticism, remarkable skepticism and resistance from the vascular surgeons. How do you meet that? Well, you meet that by continuing your commitment to the work of device development, to improving the technique. And there's no question that when you do prospective randomized trials, we learn so much, and that so much about the technique, and the rigor of the randomized trials allows us to develop even further and create the progress that we've made. So carotid stenting is now a remarkably safe and effective procedure. And again, it's a good idea that survived. It survived in medicine despite intense and repeated efforts by our vascular surgical colleagues to disprove the value of that technique.
So, yeah, this is correct. I experienced that criticism as well. Now, numerous trials have been done, and millions of dollars have been spent on those clinical trials. And we're really excited about CREST-2 that you have been very actively involved in. Do you think that this will be the final validation for this procedure to be comparable or maybe even better to a carotid endarterectomy?
The CREST-2 trial is really about asymptomatic patients, and is stenting and or endarterectomy superior to medical therapy, because we know now that we can do stenting and, for that matter, endarterectomy with very, very low complication rates. Stenting, of course, is a lot easier on the patient than having a neck surgery, although that can be done now. Stenting can be done with transcarotid approach. However, the CREST-2 trial is going to be really critical because there are a lot of skeptical, as there should be, neurologists who think that medical therapy is better than or superior to intervention with either stenting, transcarotid stenting, transfemoral stenting, or even endarterectomy. The experimental arm in the CREST-2 trial is the medical therapy arm. So what CREST-2 will tell us is that at 4 years, you're at risk, if you have a high-grade stenosis, you're at risk of stroke at whether it's 1% a year or 4% a year, we don't know. So that will be the information we'll get. And we pretty much know that once you get a stent in or have an endarterectomy, the stroke risk is very low. So the CREST-2 trial results will be out in about 6 months, 9 months. We're going to have some very valuable information, and it will open up our technique of carotid stenting, not only to prevent stroke, but I think importantly in the CREST-2 trial, we will have definitive evidence to support the contention that cognitive decline is also reduced by getting rid of these emboli-producing, flow-reducing carotid stenotic lesions.
Thank you. Gary, you continue to work on development of newest technologies in carotid artery stenting. You have been involved in design of the stents and also cerebral protection devices. Can you mention briefly what has been achieved with stent design and also in prevention of embolization during and after the procedure?
Yes, absolutely. We haven't stopped. So the most recent developments have been in having a stent which has a very, very finely produced micro mesh on the outside that prevents particles from moving through the stent struts and embolizing the brain. Despite the fact that embolic protection devices and even flow reversal have improved the rate of embolic complications, so they've really become much less. This new micro mesh technology, I think, will be, and is proved to be, remarkably effective in multiple prospective studies, and as reported recently in the FDA carefully audited study here in the United States. So it's been a big advance.
Very good. So lastly, more recently, you were involved in other totally separate area of coronary intervention, cerebral intervention, and this is a design of a large bore vascular closure device and bring it to the practice. And this is also very dear area to me. I have participated in many trials, but the Mantle device for me was a game changer as far as large bore vascular closure is concerned. Can you talk a little bit about this device and how did your interest move from carotids, from coronary to lower extremity access?
It's a good question, Zvonko. Of course, large bore access has always been something we needed, and I will just mention Andreas Grunzig really talked to us many decades ago about percutaneous valve replacement. So, but we need large bore access. The principle for innovation and development is all about an unmet need. It was a vascular surgeon, a very close friend of mine working at Columbia University, who said to me, you know, we're seeing a lot of complications associated with this transfemoral valve work. And I said to him, I said, well, I think there is a way to solve that. So the Mantle, that's how it happened. It took a year or 5 to develop the Mantle device, and it was just one interesting additional contribution I was able to make. So that's important. More recently, I would say I've got interested again in the aortic valve work. I was actually in Toulouse in 1987, working with Alain Cribier when he was a fellow, working for Brice Latac, and we were doing aortic balloon valvuloplasty. Of course, the late Alain Cribier went on to do and develop percutaneous TAVR procedures. But now I'm back in that field, and we're looking at how to modify the aortic valve with excision of the valves percutaneously using electrocautery so that we can make percutaneous valve replacement even more effective, safe, and more efficient than it currently is, particularly in terms of lifetime management of aortic valves. So I'm finding that very stimulating, very interesting, particularly as I think back to my work with my good friend Elaine Cribier back in 1987.
Yeah, it's unfortunate that we relatively recently lost him in the medical community because he was a true pioneer and luminary and visioner. Now, as far as this particular approach for modifying the deformed aortic valve, whether it's a native valve or a bioprosthetic valve, this is a true unmet need. Thousands and thousands of valves are being implanted, and then in a relatively short period of time, 4 or 5 years or so, we have to deal with the issues, what to do with a deformed valve. Can we do a valve-in-valve type of a procedure? And very frequently we deal with scenarios where it's not possible because of the high risk of coronary obstruction due to the design of the valves that we have at the present time. So your contribution in this area would be tremendous. And this is a true unmet need. And let's hope we have those devices available within the next few years or so. So thank you for working hard on this project as well, Gary.
Yeah.
And lastly, I wanted to, for those that are participating at this podcast, to show your contribution with this book, The First Balloon Expandable Coronary Stent, an expedition that changed cardiovascular medicine. That is very informative and detailed information of all the developments in endovascular medicine in the last several decades. So thank you very much for finding time and desire and ability to be able to bring this to fruition.
Thank you, Zvonko, and it's been a great pleasure to be with you for this segment.
And finally, you were the recipient of Texas Heart Institute highest award, Racy Fish Award. That was last year at our institution in January. So we were very honored to have you as one of the luminaries, and your portrait stands on the wall at Texas Heart Institute as one of the luminaries and leaders in this field. Thank you very much for accepting this award from Texas Heart Institute.
Thank you.